I have the pleasure to introduce our speaker for this week. Dr. Eric Garland is a distinguished endowed chair in research and a distinguished professor and associate dean for research at the University of Utah College of Social Work, and is director of the Center on Mindfulness and Integrative Health Intervention Development. Dr. Garland is a developer of an innovative mindfulness-based therapy founded on the insights derived from effective neuroscience called Mindfulness-Oriented Recovery Enhancement. He's published more than 220 scientific manuscripts and received more than 70 million in research grants to conduct clinical trials on mindfulness for addiction and chronic pain. In recognition of his expertise, Dr. Garland was appointed by NIH Director Dr. Francis Collins to the NIH HEAL Multidisciplinary Working Group to help guide the 1.1 billion HEAL initiative to use science to halt opioid crisis. In a recent bibliometric analysis of mindfulness research published over the past 55 years, Dr. Garland was found to be one of the most prolific authors of mindfulness research in the world. So we are very excited to welcome him to speak with us today.
Thanks for the introduction. Happy to be here. So I'm going to be speaking with you about my work on mindfulness-oriented recovery enhancement as an intervention to address chronic pain, opioid misuse, and addiction. And I do have one disclosure. So to begin, Nobel Prize winning economists Case and Deaton found that for the first time in many decades, the US mortality rate was climbing precipitously, to which they attributed in large part to the opioid crisis, a crisis that has been termed a disease of despair in the epidemiological literature. And the disease of despair has many sources, from the rising tide of income inequality to the lack of opportunity, to intergenerational violence and trauma, and the egocentric materialism and social isolation that's such a part of modern culture. And in the face of this vacuum of meaning, it was really inevitable that life would become more painful, and indeed it did. Rates of chronic pain soared in the US, where an estimated 50 million Americans experience pain each year. And to meet this epidemic of pain, opioid prescriptions climbed. In 2015, 38% of the US adult population was prescribed an opioid that year. And this dramatic increase in opioid prescriptions was paralleled by a rising incidence of opioid misuse and opioid use disorder. In 2020, 9.3 million Americans misused opioids, and 2.7 million had an opioid use disorder. Of the 9.3 million who misused opioids, 43.6% of them obtained the opioid from a healthcare provider. And that tells me that chronic pain is continuing to drive this crisis, at least in part. So I want to start this talk with a clinical anecdote. A patient came to see me for help with chronic pain and opioid-related problems. He had received a series of 5 failed back surgeries, and after each one had been prescribed higher and higher doses of opioids. He knew he had a problem with opioids. He knew he was taking too high of a dose, but as he so poignantly stated to me, I just don't want to be in pain. I asked him to tell me about a time when he wasn't in so much pain, or maybe when his pain didn't bother him at all. And he told me that on the weekends, when his grandkids came over and he watched them play in the backyard, he became so focused and so absorbed in watching them play that it brought joy to his heart. And in that moment, he didn't notice his pain. His pain was temporarily gone. And so was his desire for opioids. And this clinical anecdote is probably familiar to those of you who work with people like this. I think it hints at a potential therapeutic mechanism that could be leveraged to help address the opioid crisis. To understand this claim, we need to understand the role that hedonic dysregulation plays in pain, pleasure, and addiction. Traditionally, in Western philosophy, pleasure and pain have been considered opposites on a hedonic balance, such that increasing experiences of pain are thought to outweigh the experience of pleasure in everyday life. Modern neurobiology suggests that pleasure and pain are not mere opposites, but actually operate through a common emotional currency in the brain, mediated by the mesocorticolimbic dopamine circuit and the endogenous opioid system. And these same brain systems become hijacked by addictive drugs like opioids through an allostatic process, in which chronic exposure to drugs like opioids causes neuroplastic changes in corticolimbic and striatal brain circuitry, increasing sensitization to pain, stress, and drug-related cues, while decreasing sensitivity to the pleasure and meaning derived from naturally rewarding objects and events in the social environment. So in other words, As the individual becomes more and more dependent on opioids just to feel okay, they become less able to extract a sense of natural, healthy pleasure, joy, and meaning out of everyday life. And this pushes them to take higher and higher doses of the drug to preserve a dwindling sense of well-being, leading to the loss of self-control over opioid use that's characteristic of opioid addiction. But we know that not all people who take opioids misuse them or become addicted to them. In fact, most don't. So why can some people take opioids as prescribed by their physician, whereas others go on to misuse opioids or become addicted to them? And answering this question has motivated a great deal of my basic clinical science research program. To answer this question, we use tasks from cognitive neuroscience in my lab, like the dot probe task. In this task, there's a computer screen and it's split in two. On one side of the screen is a pain-related image. On the other side of the screen is a neutral image. These images are displayed for a very brief amount of time, after which they disappear and a dot pops up. Participant's task is to choose the side with the dot. And then the computer measures reaction times. And there's a large body of research to demonstrate that people with chronic pain are faster to find the dot when it replaces the pain image than when it replaces the neutral image. And this provides an objective index of how much their attention is captured by or biased towards pain-related information. We also pair neutral cues and naturally rewarding positive cues. And we pair opioid cues and neutral cues. And about a decade ago, my research group was the first to demonstrate that people with chronic pain who had an opioid use disorder are faster to find the dot when it replaces the opioid image than when it replaces the neutral image, indicating that they have an attentional bias towards opioid cues. And this opioid attentional bias had significant clinical consequences. It predicted opioid misuse 20 weeks following the end of treatment. So these data suggest that opioid misuse and addiction is linked with increased sensitivity to opioid-related cues. In my lab, we also measure hedonic dysregulation with the emotion regulation task. In this task, participants are presented with emotional images. In response to negative emotional images, they're asked to either view the image or to reappraise the image by reframing the meaning of the content of the image in such a way as to reduce its negative emotional impact. So to reappraise this image of this mother and child screaming in fear, one might think, the mother and child faced the tragedy, but in facing the tragedy, it brought them closer together as a family. In response to positive emotional images, participants are asked to either view the image or to savor the image by mindfully focusing their attention on what is pleasant, beautiful, and good in the image, and appreciating and amplifying any positive emotions or pleasurable body sensations arising during the savoring practice. And during this task, we measure an array of psychophysiological processes, including heart rate variability, which is the beat-to-beat variation in heart rate driven by the parasympathetic nervous system and governed by a network of brain structures involved in regulating attention and emotion. And a number of years ago, my colleagues and I found that relative to people who take opioids as prescribed, here depicted in these blue bars, opioid misusing chronic pain patients, depicted in the red bars, showed significant blunting of heart rate variability during reappraisal, viewing positive images, and savoring positive images, indicating that they have a selective deficit in the ability to shift their emotions in a positive direction. And we found converging evidence in EEG data that we published in Biological Psychiatry last year. In the top center panel, you can see brainwaves from people who don't misuse opioids. These individuals are able to decrease their brain's reactivity to negative emotional stimuli through reappraisal. They're able to calm down their brain's reactivity. Beneath in red, you can see brainwaves from people who misuse opioids. Not only can these individuals not reappraise effectively, but actually when they try to reappraise, it backfires and it aggravates the negative emotional reactivity in the brain. And all the way on the right, you can see brainwaves during positive emotion regulation. In blue are brainwaves from people who don't misuse opioids. These individuals are actually able to increase their brain's response from viewing positive images to savoring positive images. But beneath in red, you can see brainwaves from patients with opioid use disorder. Here you see total blunting of brain response during positive emotion regulation. And these deficits in negative and positive emotion regulation are associated with more severe opioid craving and predict future opioid misuse. And recently, we had a manuscript accepted in the American Journal of Psychiatry with Rita Goldstein's group, showing that the corticostriatal mechanisms of hedonic dysregulation in opioid use disorder are associated with higher levels of opioid craving. So if opioid misuse and addiction are being driven in part by hedonic dysregulation, then we need interventions that can target it. And to that end, I developed Mindfulness-Oriented Recovery Enhancement, or MORE, which is an integrative mind-body therapy that unites complementary aspects of mindfulness training, cognitive behavioral therapy, and principles from positive psychology into a treatment that can simultaneously address addictive behavior, emotional distress, and chronic pain. Now, there's a lot of stuff out there in the world, particularly in the popular press, about mindfulness. So I just wanted to spend a minute to give you my definition of mindfulness, so we can kind of have a common operational working definition. So mindfulness is a form of mental training that involves the practice or meditation practice of cultivating awareness and acceptance of one's thoughts, emotions, sensations, and perceptions in the present moment, and observing those experiences as if you were a witness, this sort of witnessing or meta-awareness capacity. So the practice is pretty simple. Essentially, what you do is you start by focusing on the object of mindfulness. And the object of mindfulness really could be anything, but the typical object that we start in teaching patients is to focus on their breath as the object of mindfulness. Then after 10, 20, 30 seconds, your mind starts to wander off into other thoughts or emotions or sensations. Then what you do is you just notice that your mind has wandered. Notice where it wanders off to. And instead of getting mad at yourself or beating yourself up about it, you just acknowledge and accept where the mind has wandered off to. Then you let that thought go and you bring your attention back to the object of mindfulness. So now you've done one loop of mindfulness, but you continue to loop through this cycle. And each time that you loop through this cycle, you're strengthening the mind's capacity to be aware of itself, to witness itself, this meta-awareness capacity. A lot of people think mindfulness is a relaxation technique, but really it's not. Mindfulness, the relaxation that's produced by mindfulness is like a nice side benefit of mindfulness. But essentially, the mechanisms of mindfulness involve controlling your attention, regulating your emotions, and cultivating self-awareness. So MORE is a sequence treatment. It begins with a foundation of mindfulness training, which by virtue of strengthening attentional control and meta-awareness is used to synergize more elaborate therapeutic techniques like reappraisal and savoring, and ultimately to lead towards self-transcendence, the sense of being connected to something greater than the self. These treatment components are intended to modulate a series of therapeutic mechanisms that are in turn intended to produce clinically significant change in a range of treatment targets relevant to chronic pain, opioid misuse, and addiction. And I would add here that MORE's been tested as a therapy for a wide array of addictive behaviors, but my talk today is really mostly going to focus on MORE as an intervention for the opioid crisis. MORE is an 8-session treatment. It's typically delivered as a group therapy. Sessions are about 1.5 hours to 2 hours long. They begin with a formal mindfulness meditation practice, followed by a debrief and group process, which is just exquisitely important in helping patients to consolidate what they've learned from the mindfulness practice, and then to generalize that learning to addressing their symptoms in everyday life. After the group process, new psychoeducational material is delivered with the session topics listed here on the left. Sessions end with some sort of experiential mind-body practice. And then there's homework consisting of 15 minutes of mindfulness, reappraisal, and/or savoring practice a day. We also ask people to stop before they take their opioids or other drugs, or before they take their medication-assisted treatment like methadone or Suboxone, and practice a few minutes of mindfulness before engaging in that practice. And the purpose of this exercise is to help patients to clarify whether their opioid use is being driven by craving or being driven by pain relief, the need for pain relief. It's also to prevent unnecessary opioid dosing by providing a non-opioid means of pain relief. And for patients who are receiving medications for opioid use disorder, doing this practice before before taking the medicine might increase their commitment to their recovery. So I just want to take a moment to describe this technique to you. We call it the stop technique. So the first step is to S, stop right before you take your medicine or your drugs. T, take a few minutes to practice mindful breathing. Then O, observe your thoughts, feelings, and body sensations while you're in the presence of the drug. So for example, if you're a person who's taking prescription opioids for chronic pain and you're having trouble with misusing them, when you take the pill bottle out and you take the pill out in your hand before you eat the pill, hold it in front of your face for a few inches and just observe your body's reaction, observe your mind's reaction in the presence of the pill. Notice how your attention becomes captured by the pill, by the sight of the pill. That's the attentional bias I was talking about. Observe that you can have an urge or a craving to take this drug, but you don't have to necessarily give in to the urge. And if you become overwhelmed, if the feelings become too intense, you can always return the focus of your attention back to your breath as a way to recenter yourself. And then finally, P, proceed with intention. If you do choose to take the drug, recognize that you're putting a powerful chemical into your brain and your body, and that deserves your respect, your attention, and your awareness. If you choose to take medication-assisted treatment, if you're prescribed methadone or buprenorphine, recognize that you're actually taking a life-saving medication and use this as a time to commit yourself to your recovery. So now I want to take a moment to talk about how we teach patients to deal with pain through more. So people with chronic pain typically experience pain as an emotionally laden, monolithic, and unremitting experience. It's this terrible, awful thing that just always seems to be there. And on top of that, people overlay a layer of suffering. They say to themselves, why me? This isn't fair. This pain is ruining my life. And that emotional anguish actually amplifies nociceptive processing in the brain. So in more, we teach patients mindfulness skills to remove this emotional overlay and to decompose the pain experience into its subcomponent sensations. So rather than focusing on some terrible, awful anguish, we ask people to use mindfulness to zoom into the experience and break it down into sensations of heat or tightness or tingling, as well as to notice the spaces in between those sensations where there's either no sensation at all or potentially even pleasant sensations right next to the painful ones. And using mindfulness to cultivate interoceptive awareness and exposure may reduce emotional bias during pain appraisal and thereby decrease the intensity of pain during pain perception. And we use a very similar technique to help patients cope with craving, breaking the craving down into its cognitive, emotional, and sensorial components. Now I want to take a moment to talk about one of the techniques in more that makes it quite unique. So patients in more are taught a mindful savoring technique, here depicted in this beautiful infographic developed by the National Center for Complementary and Integrative Health for the MORE research program. So patients learn mindful savoring by focusing mindful awareness on a rose, turning their attention towards the beautiful colors, textures, and scent of the flower, as well as the touch of its petals against the skin. And during this practice, patients are guided to cultivate a metacognitive reflective attitude and to become aware of, appreciate, and amplify any positive emotions or pleasurable body sensations arising during the savoring practice. Then they're asked to go on and practice this technique at home with naturally occurring pleasant everyday events. And this technique is intended to amplify natural reward processing in the brain, boost positive emotions, elicit meaning in life, and cultivate self-transcendence, the sense of interconnectedness between the self and the world. And through this integration of mindfulness, reappraisal, and savoring practices, MORE aims to modify associative learning mechanisms that have become hijacked during the allostatic process of addiction by strengthening top-down cognitive control functions to restructure bottom-up reward learning from valuing drug-related rewards back to valuing natural rewards. And this therapeutic focus accords with my restructuring reward hypothesis, which states that shifting valuation from drug-related rewards back to valuing natural rewards will reduce craving and addictive behavior. And in my view, not only as an addiction scientist, but also as a psychotherapist that's worked with people with addictive behaviors for about 20 years, I think this is really the essential therapeutic task in recovery. The person in recovery must relearn what is and what is not important in life, what is and what is not meaningful in life. And they need to reclaim that sense of meaning that has been stolen by the drug and reinvest that back into the people, activities, and values that they once cared about. Okay, so I've given you a lot of theory and background about MORE, but let's get into the data. So MORE is an evidence-based treatment. And recently, a meta-analysis of the randomized controlled trials of MORE was published, showing that MORE produced significant effect sizes in reducing addictive behaviors, psychiatric symptoms, and chronic pain relative to a range of active control conditions. I want to hone in on a few of these studies now and talk about it. So the first study I want to highlight is the first NIH-funded stage 2 randomized controlled trial of MORE as a treatment for chronic pain and opioid misuse. In this study, there were 115 chronic pain patients who'd been taking opioids for about 10 years. At baseline, 3/4 of the sample reported misusing opioids, and there were high rates of comorbid psychopathology in this sample as well. In summary of the findings, MORE led to significantly greater reductions in chronic pain severity and pain-related functional interference than the supportive group therapy control condition. And pain interference measures how much pain has interfered with a person's activity level, their mood, their walking ability, their work, their relationships, their sleep, and their enjoyment of life. We also found that MORE significantly decreased opioid craving, and this effect remained significant even after controlling for the effect of MORE on reducing pain. So it wasn't just that MORE was decreasing the desire for opioids because it was making people hurt less, but it seemed like it was actually targeting the addictive impulse. And in this study, MORE reduced symptoms of opioid misuse consistent with an opioid use disorder. There was a 63% reduction in opioid misuse in the MORE group compared to a 32% reduction in the support group. And I would add that these data show that our support group was an active treatment. It was reducing opioid misuse, but MORE was mo better. So sorry for the terrible pun, but when you have a treatment called MORE, there's just no end to the puns you can make. There's always more and more. And we measured hedonic dysregulation with the dot probe task. We found the first evidence in the scientific literature from a randomized controlled trial that MORE could that a mindfulness-based intervention could decrease the pain attentional bias. So after 8 weeks of treatment with MORE, patients' attention was less hyper-focused on, less triggered by the pain-related cues. We also found that MORE significantly decreased the opioid attentional bias. And we recently replicated this effect in a much larger sample in a randomized trial. So these data indicate that MORE decreases the extent to which patients' attention is captured by or triggered by drug-related cues. But some of the most interesting data from this study came from heart rate collected during the dot probe task. You can see here that across all 3 cue conditions of the dot probe task, patients in MORE exhibited significantly greater heart rate decelerations than those in the control group. Not surprisingly, the more patients' heart rate slowed as they viewed the pain and opioid images, the less aroused, the less stimulated they felt by those images. But we actually found the opposite pattern in response to the pleasurable photographs. The more patients' heart rate slowed as they viewed the pleasurable photographs, the more aroused, the more stimulated they felt by those images. And we took this to mean that maybe MORE was increasing physiological sensitivity to natural pleasure. We conducted a heart rate variability analysis and found that across the board, MORE led to significantly greater increases in heart rate variability than the control group, but these effects were most pronounced to the pleasure cue condition. So you might be wondering, who cares about this heart rate stuff? What does this have to do with treatment? So to understand the clinical significance of these findings, we conducted a multivariate path analysis and found that the effect of MORE on reducing opioid craving was statistically mediated by changing the heart rate response to the pleasure cues, not by changing the heart rate response to the opioid cues. So in other words, MORE appeared to be decreasing opioid craving by enhancing natural reward processing. And this represented the most significant finding of my early scientific career. I think you can appreciate this if you remember that one of the prevailing models of addiction neuroscience states that as a person becomes more and more addicted, their brains become less sensitive to natural healthy pleasure, and then this drives them to take higher and higher doses of the drug just to feel okay. These data suggest that this allostatic process might be reversed, that by teaching people how to savor natural, healthy pleasure, this might reduce craving and addictive behavior. And it was this set of findings that really allowed me to crystallize my restructuring reward hypothesis. In this study, we also collected ecological momentary assessments. So we had people rate their pain and their mood state up to 4 times a day, each day over the course of the treatment. And this gives you a tremendous amount of data, 224 time points per individual. We found that more was decreasing pain from moment to moment in everyday life. We also found that more was increasing positive emotions from moment to moment in everyday life. In fact, patients and more had 2.75 times the odds of those in supportive therapy to be positively emotionally regulated over the course of treatment. That means if I'm in a bad mood in this moment, I'm able to improve my mood in the next moment. Or if I'm in a good mood in this moment, I'm able to maintain that positive mood in the next moment. And interestingly, it wasn't that the decreases in pain that were correlated with reduced opioid misuse, but rather patients who showed the largest increases in momentary positive emotions reported the largest decreases in opioid misuse. And these findings supported my restructuring reward hypothesis. All right, so let's take stock. What do we know? We know that more seems to decrease addictive behavior, craving, and drug cue reactivity. We also see that more seems to decrease pain. But at the same time, more appears to increase positive emotions and natural reward processing. So, given these promising clinical findings, we wanted to replicate them. So we conducted a second stage 2 randomized controlled trial of more in primary care. And once again, we found that more led to significantly greater reductions in chronic pain and in opioid misuse than the control group by the 3-month follow-up point. We also found that more increased an array of positive psychological processes, including positive affect, savoring, meaning in life, and self-transcendence. And importantly, the effect of more on reducing pain severity and opioid misuse was linked with increases in these positive psychological processes, suggesting that one way to treat the disease of despair is to teach people how to mindfully savor natural, healthy joy, meaning, and self-transcendence in everyday life. In this study, we also found that more decreased opioid use. There was a 32% reduction in opioid use in people treated with more. We wanted to understand how more was doing this, so we brought people into the lab and had them practice mindfulness meditation while we recorded their heart rate variability. And we found that patients treated with more showed significantly greater increases in heart rate variability when they practiced mindfulness in the lab. And the effect of more on reducing opioid use was statistically mediated by these increases in heart rate variability during meditation. This is actually really interesting because heart rate variability is a well-known biomarker of cognitive control or self-control. One of my favorite studies in this area was done by Segerstrom and Ness in 2007. They presented people with a tray. On half the tray was a pile of gooey chocolate chip cookies. On the other half were some carrot sticks. And in one experimental condition, they said, don't eat the cookies. You can eat the carrot sticks, but resist your urge to eat the cookies. In the other condition, they told people you can eat the cookies if you want. And patients, when participants resisted their urge to eat the cookies, they showed this large increase in heart rate variability. So it could be what we're seeing here is that mindfulness provides a means of increasing self-regulation of your autonomic response during craving, and that enhances your self-control over your opioid use. So at the same time, we were interested in whether more could improve outcomes in people receiving medications for opioid use disorder. So my colleague Nina Cooperman and I were awarded a grant from NIH to conduct a pilot RCT of more for patients receiving methadone treatment in the community. This study was conducted in inner city New Brunswick, New Jersey, in a predominantly African-American and Latinx sample. We didn't expect to see significant findings in our pilot study, but we did. More actually led to significantly fewer days of opiate use, days of drug use, chronic pain, and depression compared to methadone treatment as usual. In this study, we also collected ecological momentary assessments, and we found that more reduced the intensity of opioid cravings by 50% by the end of the treatment. More also improved positive emotions from moment to moment. And once again, increases in momentary positive emotions were associated with decreases in opioid craving, providing additional support for my restructuring reward hypothesis. So then we wanted to replicate these results, and in an NIH-funded R33 grant, we conducted a second larger trial of more for patients with opioid use disorder being treated with methadone. This study started when COVID-19 hit, and so we had to rapidly pivot to telehealth. So we gave patients tablets that had a data plan so they could participate in the more therapy sessions over Zoom. And in a sample of 154 patients with opioid use disorder, we once again found that more led to significantly fewer days of opioid use than methadone treatment as usual, significantly fewer days of drug use than methadone treatment as usual, and patients treated with more had a significantly longer time to relapse than patients who received usual care with methadone. More also improved methadone adherence at the 16-week follow-up, and more significantly decreased chronic pain symptoms from moment to moment. So taken together, these data suggest that more is an efficacious treatment for treating opioid use disorder among people receiving methadone. All right, so let's take stock. What do we know? We know that more seems to decrease addictive behavior and craving. More also seems to decrease pain. At the same time, more appears to increase positive emotions and sense of meaning in life. And these effects are linked with increases in self-regulation and self-transcendence. So given all these compelling clinical findings, we wanted to start getting under the hood and understanding the neurophysiological mechanisms by which more was producing its treatment effects. So in a new sample of chronic opioid users, we brought them into the lab and had them participate in an opioid cue reactivity task while we measured their brain activity. And here in the red line, you can see the brain's response to viewing opioid cues before treatment. Here in the blue line, you can see the brain's response to viewing opioid cues after 8 weeks of treatment with more. You can see more just substantially reduce the brain's reactivity to the opioid-related cue. And on the right, you can see brainwaves for patients undergoing standard supportive group therapy. You see really no difference at all in brain response before and after treatment. And if you have trouble reading the squiggly lines of the EEG, here's a bar chart that shows the effect. A massive decrease in brain drug cue reactivity generated by more. And this is the first evidence from a randomized controlled trial in the scientific literature showing that a mindfulness-based intervention can reduce drug cue reactivity in the brain. And given the novelty and clinical significance of these findings, they were published in Science Advances a couple of years ago. But in another randomized mechanistic experiment, we showed that more increased neurophysiological responses during viewing and savoring of natural healthy rewards. We found that more increased the late positive potential of the EEG and skin conductance responses during viewing and savoring of natural reward cues. We also found that more increased positive emotions in response to viewing these cues of smiling babies, lovers holding hands, families connecting. And the effect of more on reducing opioid misuse was statistically mediated by increases in this positive emotional reactivity. And so these data also provide strong support for my restructuring reward hypothesis. This idea, again, that if you can help people to shift from valuing the drug back to valuing natural healthy rewards, this will reduce craving and addictive behavior. And so these findings bring me to the largest clinical trial of more ever conducted. This was a NIDA-funded R01 grant. It was a 5-year randomized controlled trial. There were 250 chronic pain patients, all of whom were misusing opioids at baseline. We randomized them to receive either 8 weeks of more or 8 weeks of standard supportive group therapy. The study interventions were delivered in primary care clinics in the same doctor's offices where patients were receiving their pain management. Patients reported pain levels of 5.5 out of 10 on average. They had been in pain for about 15 years. They were taking high opioid doses at baseline, 101 morphine milligram equivalents a day on average. 3/4 of the sample reported 2 or more chronic overlapping pain conditions, and there were high rates of psychopathology in this sample as well. Nearly 70% met criteria for major depressive disorder. 62% had a full-blown opioid use disorder, 21% had a non-opioid substance use disorder, and there are high rates of generalized anxiety and PTSD as well. And in summary, the findings, using an objective index of opioid misuse that triangulates self-report, blinded clinical interview, and a drug urine screen, more reduced opioid misuse by 45% at the 9-month follow-up point, nearly tripling the effect of standard group therapy, an odds ratio of 2.94. More also reduced opioid use. 36% of patients treated with more were able to cut their opioid use in half or greater, and more reduced opioid craving from moment to moment, as measured by ecological momentary assessments. So taken together, these data clearly demonstrate that more is an efficacious treatment for reducing opioid misuse and addictive behaviors towards opioids. At the same time, more significantly decreased chronic pain symptoms and emotional distress. 50% of patients treated with more reported clinically significant reductions in pain, and the effect sizes that we observed for more on reducing pain exceed those observed for the current gold standard psychological treatment for chronic pain, CBT. But more also improved an array of mental health indicators as well. For example, more produced significant effects on depression. Recall that about 70% of patients met criteria for major depression at the beginning of the study, but 9 months after treatment with more, patients' depression symptom level no longer surpassed the threshold for having a major depression. More also had powerful effects on PTSD symptoms. 45% of those who surpassed a validated cut point for a PTSD diagnosis on the PCL reported clinically significant reductions in PTSD symptoms. And these data were just accepted for publication in Nature Mental Health. More also improved positive emotions, meaning in life, and self-transcendence. And these data suggest that more is a broad spectrum treatment that can simultaneously address addiction, chronic pain, and the comorbid psychiatric conditions that often fuel these problems. And we recently replicated these results in a 5-year DoD-funded clinical trial comparing more to supportive therapy for 230 veterans and active duty military personnel with chronic pain who were on long-term opioid therapy. And once again, we showed that more outperformed the supportive group therapy control condition in reducing chronic pain symptoms. More also reduced opioid use by 20.7%. And at the same time, more significantly decreased opioid craving, pain catastrophizing, and anhedonia, while improving positive affect. So replicating these findings across 2 large randomized controlled trials really provides additional confidence in Moore's treatment effects. But we've also shown that more increases natural healthy reward responses. This is a computerized body map developed by my colleague Adam Hanley and myself. And on this body map, patients locate pleasant and unpleasant sensations. Pleasant sensations are represented in blue, unpleasant sensations are represented in red, and the density of the hue indicates the frequency with which a given part of the body was identified as feeling pleasant or unpleasant. You can see here that more massively increased pleasant sensations in the body. And it also powerfully shifted the ratio of pleasant to unpleasant sensations. So at the beginning of the study, patients reported experiencing about 1 pleasant sensation for every 4 unpleasant sensations. And I just find that really sad. I think it speaks to how much these folks were suffering. But 6 months after being treated with more, patients reported 2 pleasant sensations for every 1 unpleasant sensation, indicating that more taught people how to internally self-generate natural, healthy pleasure, thereby shifting the sense of the body from being a place of anguish to becoming a place of refuge. And finally, we were interested in how self-transcendent experiences produced during deep meditative states might reduce addictive behavior. So in a new randomized mechanistic experiment, we brought chronic opioid users into the lab and we had them practice mindfulness while we measured their EEG responses before and after treatment with more or supportive therapy. We found that patients treated with more showed significant increases in frontal midline theta EEG activity during mindfulness meditation, and Higher levels of theta were associated with more intense self-transcendent experiences during meditation. And they mediated the effect of more on reducing opioid use through a 4-month follow-up point. Frontal midline theta is a well-known biomarker of cognitive control, but it also increases during states of flow, when the normal sense of self is suspended and transcended during deep cognitive absorption with ongoing activity. And these data suggest that mindfulness meditation may provide a means of endogenous theta stimulation of the prefrontal cortex and thereby enhance inhibitory control over opioid use. And we recently replicated these results in the largest neuroscientific study of mindfulness as a treatment for addiction ever conducted. And this study was published in the top journal Science Advances back in October. I did use the phrase self-transcendence in the title, and they did publish it. So that either means that I'm a nerdy scientist or a big hippie, or maybe both. So you can decide for yourself. But in all seriousness, in this study, there are 165 chronic opioid users, and we found that more increased frontal midline theta, EEG, activity, once again, during mindfulness meditation. Higher levels of theta were again associated with more intense self-transcendent experiences, and they mediated the effect of more on reducing opioid misuse through a 9-month follow-up point. So replicating these results across 2 independent randomized controlled trials with 2 independent samples suggests that we very well may have indeed identified the key mechanism by which mindfulness reduces addictive behavior. All right, so let's take stock. What do we know? We now see clearly that more decreases addictive behavior and craving, and at the same time, more decreases physical and emotional pain. But more also boosts positive emotions, the sense of reward and meaning in life, and more produces these effects by increasing self-regulation and self-transcendence. And so taken together, this body of work supports my restructuring reward hypothesis, which suggests that increasing sensitivity to natural healthy pleasure, meaning, transcendence, empathy, and compassion may actually outweigh the pull of drug-related reward and thereby reduce addictive behavior. So now I'd like to talk about some of the future directions of this work. One key future direction is to integrate more and optimize it by combining it with other neuroscience-informed therapeutic approaches, for example, neurofeedback and neuromodulation. I'm also interested in combining more with just-in-time adaptive interventions. I'm interested in combining more with virtual reality and with psychedelics. I just want to highlight 2 of these areas now. So we recently completed a pilot randomized controlled trial of more plus orbital frontal cortical neurofeedback during savoring. In this study, after patients learn the mindful savoring technique in session 4 of more, we bring them into the lab and give them 3 neurofeedback sessions in which we use functional near-infrared spectroscopy, or FNIRS, to provide real-time information about the extent to which the patient is activating their orbital frontal cortex as they savor a real physical rose. And we're comparing this condition to the standard MORE intervention and to supportive group therapy. And we do have hot off the presses results from this trial. We observed a significant linear increase in orbital frontal cortical activity during viewing of natural reward cues during the positive emotion regulation task from the supportive group therapy control condition to the MORE group and to the MORE plus neurofeedback group. We also observed significant specific and focal activation of the OFC during savoring only for the MORE plus neurofeedback condition. And importantly, we found that increases in OFC activity during natural reward processing were associated with significant reductions in opioid misuse following treatment. And these data again provide support for my restructuring reward hypothesis. So given these promising clinical findings, we want to scale up this work and conduct a full-scale randomized controlled trial next. I also recently had a new paper accepted in the journal Mindfulness detailing a pilot randomized controlled trial we conducted of MORE plus just-in-time adaptive interventions triggered by wearable sensors. In this study, we use a commercially available Garmin wearable to detect physiological stress. When the Garmin detects physiological stress, it triggers the patient's smartphone to ask them if they'd like to practice mindfulness as a way to reduce their stress. Then that leads their smartphone app to play a mindfulness audio recording to guide them in the mindfulness practice. We combine this Jedi intervention with the full Moore intervention, and we found that the Moore plus Jedi intervention resulted in significantly greater reductions in opioid craving and in pain from moment to moment in everyday life. My colleague Tauhida Rahman from UCSD and I conducted a machine learning analysis of the physiological data collected by the wearable to predict the therapeutic impact of the mindfulness Jedis. And Dr. Rahman's models achieved an adequate level of sensitivity and specificity in terms of being able to predict the effectiveness of this mindfulness Jedi. And so this leads us to envision a closed loop system in which physiological signals collected by the wearable are analyzed with machine learning to provide a personalized mindfulness-based treatment approach, selecting the right mindfulness technique for the right patient at the right time. Another key future direction of this work is to implement more, especially given now that we know that it's clearly an efficacious treatment for chronic pain and opioid misuse. We want to use implementation science to understand the best way to deliver this evidence-based therapy and standard of care. And currently, more is being implemented in multiple healthcare settings, including addictions treatment, community mental health, oncology, pain management, and primary care. I think primary care is one particularly promising venue for implementing more. And that is because I think more simultaneously addresses substance use disorders, psychiatric disorders, and chronic pain conditions. So these are the high utilizers that put a lot of burden on the healthcare system. And so having an intervention that can simultaneously address these conditions would be really efficient and resource effective. And more is already able to be delivered as an insurance reimbursable service. It's currently being delivered as an insurance reimbursable group medical visit by physicians, nurse practitioners, PAs, social workers, and psychologists. And I think that also bodes really well for the dissemination of this therapy across the country. We need to make this affordable and accessible to people. Another way to increase access to this evidence-based treatment is to extract the most potent techniques from the Moore intervention and deliver them in a brief, kind of scalable format. And we've tested this in a variety of settings, including in the inpatient hospital setting and in people undergoing orthopedic surgery. We're giving them a single session of mindfulness preoperatively to try to improve their outcomes postoperatively. And a number of years ago, we conducted a randomized controlled trial of the mindful breathing practice from the Moore intervention in patients who were in the hospital experiencing acute unmanageable pain. So this really was pain from anything that would be hurting somebody in the hospital. So it could be musculoskeletal trauma, it could be pain from a heart attack, pain from an infection, burn pain, anything under the sun. When patients were experiencing unmanageable pain and they reported it to their nurse, it would send a flag in the electronic medical record to get their social worker to come down to the hospital room. Social worker came into the room and provided simple scripted 15-minute mindfulness practice. And we found that 15 minutes of mindfulness reduced acute pain by 25%. Now that's about as much pain relief as you would expect from 5 milligrams of OxyContin. So that leads me to wonder if a simple scripted 15-minute mindfulness practice can reduce pain by that much, then why aren't we using mindfulness everywhere in the healthcare system where pain is encountered? So in conclusion, Moore is an efficacious treatment for addiction, emotional distress, and chronic pain, as demonstrated by 9 randomized controlled trials to date involving more than 1,000 patients. And there are actually multiple other large trials of Moore underway that they should be finishing up in the next couple of years. And that's going to bump this number up even higher. So I think we can really confidently say this is an evidence-based approach. We've learned a lot about how MORE works over the past decade. MORE's mechanisms of action include decreasing drug cue reactivity, increasing natural reward processing, enhancing self-regulation, and eliciting self-transcendence. It's now time to optimize MORE. And as I said, I'm interested in enhancing MORE's treatment effects by using neuroscience-informed approaches, including neurofeedback, neuromodulation, virtual reality, and psychedelics. It's also time to disseminate MORE, and that's been a main focus of my work over the past several years. I'm really passionate about bringing this work to the people, training folks in MORE, so that this intervention can be delivered across the country. And so to date, I've trained more than 750 social workers, counselors, psychologists, nurses, and physicians from around the US and internationally in MORE. And there are currently several large healthcare systems that are delivering MORE as an insurance reimbursable service, including Essentia Health, which is a large integrated healthcare organization in the Midwest. And they are successfully achieving insurance reimbursement for this intervention. But ultimately, teaching people to take in the good and mindfully savor natural, healthy pleasure may provide the learning signal needed to restore adaptive hedonic regulation and ultimately to reverse addiction. And I know that's a bold claim, but we're facing a serious crisis in this country. And I sincerely hope that my 2 decades of work as a psychotherapist, addiction scientist, and biobehavioral intervention researcher have had some positive impact on the opioid crisis. So I want to thank you for your attention. I want to thank the funders of my work, including the National Institutes of Health and the Department of Defense. I am holding a MORE training on July 6th and 7th by Zoom. So love it if you could make it. And I do hold several trainings a year that are open to anybody. I also hold trainings in MORE for agencies. So if your agency or treatment center is interested in getting trained in MORE, please reach out to me and we can schedule that at your convenience. But I think we have plenty of time for questions now. So if anybody's got anything, I'd love to answer it for you. Thanks for your attention.
Yes, thank you so much, Dr. Garland, for your presentation. I found it to be very, very interesting. So, of course, if people feel free to come off mute to ask questions. If there are any, of course, can use the chat or raise your hand, whatever makes you most comfortable. The first one that I see in the chat right now was if training leads to a certification, if someone attends the MORE training.
Yes, that's a great question. So there is a certification pathway for MORE. The basic, I'm holding the basic training on July 6th and 7th, and that's the first step in achieving certification. The next step is to complete an advanced training, which is also a 2-day training. And then after that, what you've got to do is you have to actually deliver MORE with clients. You're going to have to audio record a session and send it in where we can evaluate the quality of the fidelity of the intervention delivery. Is the therapist delivering MORE with competence? Are they sticking with the treatment manual? And once the person can demonstrate that they can do this well, then they'll be certified at that point. But I would also say you can actually practice MORE in your clinical practice before certification. So completing the basic workshop is enough to start using this in your practice.
I have a question.
Yeah.
Did you find a difference between someone that considered themselves to be an addict versus someone that had just been taking opiates for like 10 years with their cravings?
That's a great question. My short answer is no, we haven't formally looked at that yet. That's something that I hope to do now that that veteran study is complete. So now we have about 500 patients that have gone through this intervention and the same kind of research design. We have enough data now that we can do what's called a moderation analysis and try to understand which subgroups of patients respond better to the treatment. So I haven't done that formally yet. It's a really good idea. I can tell you though that in eyeballing the data, when I look at it, it actually seems like the people who are more severe do better. They're the ones who actually get the most benefit from this treatment.
Because when you were talking about the stop scenario, somebody that, you know, is considered an addict that wants more and more and more, when they look at the pill versus someone that has done 10 years that maybe not consider themselves as an addict, when they do it, I still feel like maybe they would have cravings also, because they would have withdrawal symptoms and stuff because they've been doing it 10 years, but they didn't have the, you know, the urge like maybe I would have. So, you know.
You're right. Yeah, that's a great observation. In fact, I think that technique is almost even more critical for those folks, because they may not be aware that they're having a craving. They may think that they're taking the pill simply to alleviate their pain, and they may not realize that actually part of the motivation is being driven by craving, but that's an unconscious craving. They're unaware of it. So when the person has this habit, they've been taking this pill, let's say 3 times a day for 10 years, you know, they don't even think about it. It's just on autopilot. And so what we're asking them to do is actually to stop, to interrupt the automatic habit, and to bring some conscious awareness to it. And when they do that, then they start to notice the craving that's been there all along that maybe they were unaware of. So I agree.
And as for the heart rate slowing down in some of the studies, would being jaded and doing the process over and over, the brain and the person just kind of getting used to it, wouldn't that also lower the heart rate? So would that change the study at all?
You've got some great observations, man. You got a future in science. Yes, absolutely. That's why when you do these kind of studies, it's critical to have a randomized controlled trial research design. And that what you're talking about is habituation. When you show people the same images multiple times, they get used to it. So it stops activating their brains and their bodies as much. But that habituation should happen for both groups, the more group and the control group. And so what we're showing is that people who are treated with more, they show less reactivity in their brains and their heart rate, even when compared to a control group. So that's above and beyond the effects of habituation.
That's all I got. Thanks.
Thanks. Great questions.
Dr. Garland, thanks so much for taking the time. As the director of KY Open, we really appreciate you sharing your perspective and bringing sort of a unique idea into these communities that are thinking about how to solve the challenge, not just of opioid use disorder, but the issue of despair. The question that I have regards care for patients coming from rural communities. Most of the of more, and correct me if I'm wrong, is happening in sort of group settings, right? And sometimes in person, sometimes virtual. So I'm wondering if you could share a little bit about how to overcome the challenges for more rural patients who may not be able to get into, sessions once a week or drive there. How do we reach that population?
Yeah, it's a great question. So I have several reflections. One is that a lot of this work was done in Salt Lake City, which has a pretty big rural catchment area. So we're getting people from really out in frontier areas in the mountains and the desert. But I think, first of all, telehealth is a really good option for helping to reach people who live far away, who couldn't possibly meet a weekly group. So that's one option. And now that we have the data from the New Jersey study showing that telehealth more works, I think that opens up a lot of doors. We've had to be really flexible in intervention delivery. So for example, when people miss sessions, one thing that's really helped is by offering makeup sessions to people. And that it is kind of burdensome on the therapist's delivery, but really helpful for people who have busy lives or who are living in rural areas. And then the other option is to deliver more as an individual therapy, which is something that we're currently studying in several large trials. And so we don't have full results yet, but looks like it's feasible that way, and looks like it's helpful in that format as well. So I agree. I think we need to be as flexible as we can be. I mean, I haven't talked about this, but one of the weaknesses of MORE is that it's really structured to be a closed group format. So the sessions are the building on each other. The sequence is building on prior knowledge. And that makes it tough, because if you have people dropping in and out and all over the place, how do you get them that training in that sequence, in that order? And so I do think more flexible open group models might also be useful in the future. So we need to come up with new ways to make this more accessible to folks. But really the first step was just to show that it works, and it does.
Thanks so much. I think I saw a hand raised.
Yeah, I think Brandy, maybe you raised your hand, but then it put back down. So I'm not sure if you meant to raise your hand or not. Okay.
It was an accident, but I do want to say that I have had some mindfulness training with my clinician in the past, and I'm from a rural community. But little videos like leaves on the stream and different things like that has been really helpful. You know, me working with my own clients in recovery.
Nice. Yeah, I think whatever extent you can insert some of these techniques into your standard of care practices, it's probably going to be helpful. And then doing the full structured evidence-based approach is going to help even more, unintended. But while we're here, just to underscore, and I don't think I said this, but in case you don't know, the data shows that about 50% of patients with an opioid use disorder have some sort of chronic pain. So it's a lot more common than you think. Your clients, they may not be talking about it, but it's a real factor out there. Some of that may have been a chronic pain condition for which the patient took a prescription opioid, and then they moved on to develop addiction to heroin or fentanyl or something like that. But there is some evidence actually that long-term opioid use can actually cause pain as well. And so for whatever reason, it's pretty common among people with an OUD. And so it's really important that not only we're addressing the addiction, but we're also addressing the physical pain and the emotional pain that are driving the addiction. And I think MORE has a lot of promise in that regard.